Welcome, everyone. I'm Dick Deming. I'm Medical Director of Mercy One Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. And our topic this evening is everything you wanted to know about menopause. And our guest is my friend and colleague, Dr. Karen Kemp-Glock. Welcome, Karen.
Hi, thank you for having me.
Thank you for being here. Before we talk about the topic, let's get to know you a little bit better. So
Sure.
tell us a bit about yourself. Where were you born and where did you go to high school?
Well, I was born in Athens, Georgia. My parents were living in Seguin, Texas at the time, and Dad was back in Athens working on his graduate degree. And then I grew up in Ames, Iowa, and graduated from high school in Ames.
In Ames,
Yeah.
so went to Ames High School.
Yep.
What was your claim to fame at Ames High?
I don't know that I had one.
Sports, music?
No, I was just kind of one of the run-of-the-mill kids. I didn't do a lot of music or sports. I danced through my younger years in high school, but yeah.
And then where did you go to college?
I went to Texas Lutheran College back in Seguin, and then I did a master's at the University of Iowa, worked for a couple of years, and then I went to DMU to medical school.
Okay. So back when you started college, what did you have as your major when you first started college as a freshman?
My freshman year was economy,
Okay.
economics.
What was your dad's field?
He was a veterinary parasitologist.
Oh, okay.
So he got his undergraduate degree in some biological science and then did a graduate degree in parasitology. And then I ended up graduating with a degree in chemistry. So I changed after that first year.
And then what was your master's?
In chemistry.
And then when did you decide that you wanted to become a physician?
Well, it'd always been kind of in the back of my head. My mom is a nurse, so I was around medicine, and then my dad worked in the vet school. And then kind of solidified after I got out and worked and realized I wanted to go the medicine route.
Okay. And you're in medical school, and like all of us, you get to do rotations in all sorts of things, pretty much everything.
Yep.
When did you decide that OBGYN was where the direction you wanted to go?
Before I went to medical school.
Oh, really?
Yeah. Yeah.
Okay.
I always liked women's health. I liked babies. I liked the procedures. So preventative care. So I always was going in planning to do obstetrics.
So
Yeah.
DMU for medical school,
Mhm.
and then where did you do your residency?
I did my residency in Muskegon, Michigan, through the Michigan State University system.
Okay.
Yep.
Then you returned to Iowa.
Yes, to Des Moines.
Okay.
Yep.
And over the years, I'm sure that you have delivered many, many babies.
Yep.
And fortunate for our women that are experiencing issues, especially breast cancer and gynecologic cancers, lots of issues related to kind of treatment-induced menopause, that you've now specialized in menopause health and female
Yes.
sexual health.
Yes, I do. So I was in private practice when I came back to Des Moines and stepped out of that in 2016 to pursue some different areas of interest, and then kind of came full circle back into the Mercy family, mainly doing perimenopause, menopausal medicine, and office gynecology. And I don't deliver any more babies. I delivered my last baby last summer. And I don't do surgeries anymore, so I get to concentrate just on this aspect of women's care.
I always think that must be such a demanding specialty, the obstetrics. You probably were in it long enough that your practice style changed. I mean, back in the old days, they were doing everything, and everybody was on call all the time, and a little bit more a division of labor and sharing call, or how did your career span the change in practice?
Well, when I first started practice, there were 4 of us in my group, so it was call every fourth, a 1 in 4 call rotation, and then
you're still working on the day that
Yes.
you were on call.
Yes, and then overnight call, and we may have a half a day off, and then that was still kind of our rotation when I left private practice. We had more people in the practice, so it was 1 in 6, so that was a little more tolerable.
Mhm.
And then I did hospitalist medicine, so it was shift work. So I'd work a 24-hour shift and then be off for several days. And then now I'm just
An OB hospitalist.
Yes.
So yes.
Yes.
So the newer tradition is you've just got a doc in the hospital who's delivering the babies rather than on-call docs coming in.
Well, it was a combination. So there were hospitalists that were in the hospital all the time to help provide backup and emergency care to the docs that were still coming in on call.
Okay.
So, yeah.
And now your practice specializes in menopause, perimenopause. What's the various terms that are used in the medical profession to describe this type of practice that you have?
Well, I'm basically just an office-based gynecology. So, but when we talk about menopause and perimenopause and premenopause, basically what we're talking about is premenopause is when a woman is in her cycling years, her reproductive years, having regular menstrual cycles. And then as the ovaries start to decline in function, and we start to see some variation in hormone levels and cycles and some of those symptoms that start, menopausal type symptoms, that's the perimenopausal time frame, that time frame surrounding menopause. And then after a woman hasn't had her period for 12 months, she's considered postmenopausal. So we kind of throw around the term postmenopausal and menopause sort of simultaneously.
Mhm.
So
And you defined it as a woman who's not had her period for more than a year. It doesn't require laboratory confirmation to say that a woman's in menopause?
no, not necessarily. So it's a clinical definition. So for women that don't have a period because they've had a hysterectomy or maybe a uterine ablation or they're on a medication that stops the period or they're having chemotherapy that stops their period. Sometimes we'll test in that situation to see where they're at for to help guide therapies and things like that.
And we'll talk about it, but women that are on anti-estrogen therapies, it's a different treatment if you're prior to menopause versus after menopause. And so oftentimes there'll be a change in medications once the determination is made that you've gone into menopause, either because of naturally or because of the chemotherapy that it might precede the.
Right. Or if it's induced, if you're put on Lupron or something to. Yes, exactly.
So you gave us a little bit of a primer about the terms premenopause, perimenopause, and menopause. Maybe a little bit of physiology of what are the hormones made by the ovaries? How do they work in terms of the function of the uterus? And then what are the common symptoms that women experience when they go through a natural menopause?
Right. So the normal menstrual cycle, at the beginning of the menstrual cycle, which would be the first day that a woman starts bleeding, her estrogen levels are starting to rise. There's a feedback loop between her ovary and her brain. And so then the follicles are recruited and a follicle becomes mature. And then through this feedback loop, it's released. And then once the egg is released from the follicle, that particular spot is called a little corpus luteum cyst. It starts making progesterone. So the last half of the cycle, the estrogen's higher, the progesterone's higher. And if there's no pregnancy, the body gets that signal, that little cyst dries up, the hormone levels drop, and that signals the period. So that's, in very basic terms, the menstrual cycle. So as women approach perimenopause, the ovary starts to decline in function. So she may be having cycles where she's not producing an egg. So the signals between the brain and the pituitary gland in the brain and the ovary, that feedback loop kind of creates a situation where the hormones that the brain produce increase, the estrogen's decreasing, and women start to become symptomatic. So symptoms that are very common during this time, they may see a change in their menstrual cycle, where maybe they start skipping periods. The periods might get shorter, they might get longer, they may get heavier, they may get lighter. They may start having symptoms of hot flushes and night sweats, which we call vasomotor symptoms, sleep disruption, A big symptom that women tend to have and come in with is mood disorder. So increasing symptoms of anxiety, depression, irritability, not feeling themselves. They think they're going crazy. Literally, that's what I hear every day. They may have some memory issues where they can't grasp words or remember people's names. Muscle and joint aches and pains, vaginal dryness, decreased lubrication, sometimes issues with sexual function. So all those constellation of symptoms, she may have some, she may have none. They may be mild, they may be severe. It can be a combination of all of the above.
And before we bring cancer into the picture, are there any lifestyle choices that a woman can make that keeps her premenopausal longer? Does the date at which the ovaries stop working, do you think that's kind of etched in stone, if you will, and that it's going to happen at a date? Or does the way a woman lives her life, or what she eats, how she exercises, whether she takes supplements, not hormone supplements, do any of those affect how long a woman remains premenopausal?
A little bit, but mostly it's predetermined. Women when they're born with a number of follicles they're going to have.
Yep.
And so when they're in utero, they have a whole lot. And by the time they're born, that's come down from millions to like 400,000. So it's kind of predetermined, but there are some lifestyle issues that may affect menopause. Smoking is probably the main one that we may see women that smoke go into menopause a little bit earlier. Other than that, not really.
Okay. I've heard that that young girls, when they approach menarche, having a period for the first time, that the age in the United States has changed, and that's happening much younger.
It seems to be dropping a little bit, yes.
What do we think is the cause of that?
I don't think we're 100%
Okay.
sure.
I
I think there's some speculation, perhaps, that maybe there's some more estrogen type compounds, perhaps, in our environment that might be contributing to it, but I don't think they know for sure.
Okay.
Yeah.
So now, again, talking about a natural situation where a woman goes through natural menopause and starts having those symptoms. What's the remedies, and are there dietary changes? Are there over-the-counter supplements that can help? Obviously, giving someone estrogen is likely to benefit them. What are the other medications that may be helpful for women who are having menopausal symptoms that are affecting her quality of life?
Sure. So in that perimenopausal time frame, options to treat kind of depend on the symptoms she's having. So if she's still having cycles and they're kind of irregular, sometimes we'll actually use oral contraceptives or birth control pills, even if they don't need them for birth control. So if they've had a tubal ligation or their partner's had a vasectomy, giving hormones back in that fashion is very effective for controlling cycles, because a lot of these women have problems with bleeding, and it can help control symptoms too. Sometimes we'll place an IUD that has a progestin in it, like a Mirena IUD, that can help with bleeding problems, and then we'll layer estrogen on top of that.
If you put a woman on birth control pills, and you promote a normal cycle, can that continue beyond the age that a woman would normally go through menopause?
If there's no contraindication of being on the birth control pill, a woman can safely be on it till about 54 or 55.
Okay.
Yep. She may continue to have periods on it. She may stop having periods on it. It can be a little bit variable. And then other options to treat. There are some over-the-counter supplements, and they're like any over-the-counter supplement, that there's not a lot of research or data on it, but things like black cohosh, some flower pollens are out there that may have some effect.
How about vitamin E? Is that something that's helpful?
Not really.
Not really. Okay.
So there's no data on
But
it.
then again,
So-
placebos are probably
Right,
40%
Right,
effective.
right. So the one that has the most data would be the black cohosh.
Okay.
There are some soy products out there, and it just depends on how people metabolize them, some soy isoflavins. And then there are some non-hormonal medications to treat symptoms. So those can be aimed at if the major symptoms are more of the emotional component, some of the anxiety, depression. There are some antidepressants that are very effective in this age group, and they can also help with hot flashes. And there's a medication that just came out about 18 months ago called fezolinetant or Veoza, which is directed at treating hot flashes in menopausal women, but we can use it in perimenopause too. And it works in an area of the brain called the hypothalamus and blocks in a system there called the neurokinin 3B system. And then there are some other medications.
So that medication would not be contraindicated in someone who had, let's say, breast cancer and was receiving anti-estrogen therapy. There's no contraindication.
There's no contraindication to that. There's no contraindication to the antidepressants in those women either, with the exception of women that are taking tamoxifen can't use like Paxil and fluoxetine because of the interaction. The other medications that we have available that we have clinical data on that are considered off-label, and that would be gabapentin and oxybutynin, which can be effective for hot flashes, and they carry their own side effect profile. But all of that group of medications are non-hormonal. So they are indicated for women that cannot or choose not to use hormones.
Right. So let's talk about hormonal treatment of menopause. And by hormones, we're talking estrogen and progesterone. Are there others?
Sometimes we'll use testosterone,
Oh, okay.
depending, and that's not used routinely to treat menopausal symptoms. But if a woman has decreased libido, some arousal issues, sometimes what we call hypoactive sexual desire disorder, then there's some information in the literature that supports testosterone use in those women for that symptom. But as far as like energy and muscle growth and things like that, it's not recommended. So we kind of reserve the testosterone for the sexual function in postmenopausal women.
Okay. So now let's talk about the use of estrogen or estrogen and progesterone in treating menopause. So the studies have maybe matured over time, and certainly recommendations have changed since I was in medical school and you were in medical school. I know there was a time where it was really common to treat every woman with estrogen, and the thought was that it doesn't do anything bad. It's all good. And then a study came out, I don't know, it was back in the 80s maybe?
2002, I think, was the publication of the Women's Health Initiative.
Okay.
Yeah.
Where, and what did that show in
Well,
terms of the routine use of estrogen to treat menopausal symptoms?
That was a study that was put together, and it had about 23,000 women in it. And it was a study that was developed and meant to study the effect of estrogen on cardiovascular disease and if it would help prevent cardiovascular disease. And what they found in that during the course of that study was that there was a group of women that did have a small but measurable increased risk for breast cancer. So the study was pulled early. And then that was the time when we saw hormone prescriptions drastically decline because of the concern about the risk for breast cancer on hormone therapy. So in the intervening 20 plus years, that study has been dissected and researched, and there's been a lot of clinical data. And what unfortunately, that kind of was grabbed as the headline and came out of there, but there were a lot of other things that came out of that study that weren't revealed, at least not to the general public. So
did it also show an adverse effect on cardiovascular health? Or
yes and no. There was all-cause mortality was actually decreased on hormone therapy. There is a small but significant, a small but measurable increased risk for cardiovascular disease and stroke if it started later. And part of the problem with the study is that the average age was 63 of the women that were enrolled. So about 10 to 13 years after menopause. So the long story short, what has come out in the intervening 20 years is that generally it's deemed safe to use hormone therapy in appropriate patients if we start it within 10 years of menopause or under age 60. And where we see a lot of some of the adverse effects, or if we start it later. And that's where we see some of those problems. They're still small, but we see them there.
And I would imagine you see just dramatic improvement in symptoms with estrogen for treating menopausal symptoms.
Yes, a lot of women say it's life-changing.
Yeah.
So,
and then what's the conversation when you say, okay, you've been on it for 5 years, 10 years, and really the studies indicate we probably should start tapering, or how does that conversation go?
So the Menopause Society, in their initial hormone, well, not their initial hormone statement, but the previous one to the most recent one that came out in 2022, was that it should be stopped at 5 years. That has since been changed. And so we have more data on long-term use of hormone therapy. So now there's no specific age or time frame that it should be changed. It's individualized, but it's also not something that we put women on and say, you're going to be on this for the rest of your life. So the conversation I have is that the premises is to treat the symptoms with the lowest dose of estrogen for the least amount of time. And it's that least amount of time that's the moving target.
But you can't really know.
Right.
Until there's a little bit of a trial and error.
Right. So we have a conversation that every year we talk about what are the benefits of being on it? What are the risks of being on it? Is there any change in your health status? And what's your personal risk tolerance? So most women that start it are generally coming in around that time of the transition when the symptoms are the worst. And they generally are on it for at least a few years. And then, we have that conversation. And as we approach that time where we know the risk of breast cancer increases slightly, it's about 0.3%. That's about the 5 to 7 year mark. And that's a lot of times when women will say, well, I want to try to come off of this. So we don't have a test that says when you're going to stop having symptoms. We trial you off of it. And if you don't have symptoms, we don't continue it. And so the average duration of the hot flashes, which are some of the most bothersome symptoms, is 7 to 10 years. So.
And for women who go through natural menopause, is that what you're saying? The average amount of time where you might expect to have hot flashes is 7 to 10 years?
Yes, but we know that like for African-American women, that might be longer. Asian women, it tends to be less. I have women that are still having them 20 plus years out. So, yeah.
Okay. The ability to get estrogen it's readily available, as is testosterone for men. I mean, there's clinics that just sort of pop up that
women too.
Their whole idea, their whole purpose seems to be to sell hormones, and sort of with the mystique of promoting youthfulness and strength and vitality. And what do you see as some of the risks of that type of availability?
Well, one of the risks is if patients aren't being screened adequately to make sure that they're appropriate candidates, or if there's any contraindication to using the medications. And then an appropriate conversation as to the risks and the benefits, and then adequate follow-up. So, and then what we see with a lot of the testosterone is the levels are way too high. They're higher than the normal female levels ever were with some of the implanted testosterone. So I don't do any
implants. And are you
implants.
talking for women?
Yes, for women. I don't do any.
Yeah.
I really can't speak to the male aspect of it because I don't treat men. But yeah. So, and then the other thing is a lot of those clinics that are online or the boutique hormone clinics, they're doing compounded hormones, which are the same medications that we prescribe, but they're not regulated. So the dose can vary from batch to batch or even within the container. And then insurance oftentimes doesn't cover them, whereas they'll cover the ones prescribed like through our clinic or through your practitioner.
Okay.
Yeah.
Let's transition and now bring in the added complexity of having cancer. So the breast cancer is the most common cancer in women, and its treatment is complex, but often the treatment will affect uh, hormones, affect ovarian function, and affect um, in reality sort of bring menopause earlier. So in women that are premenopausal, they may be getting chemotherapy, which can affect the function of the ovaries. And then if a woman has estrogen receptor positive breast cancer, then it's very common that you actually bring anti-estrogen treatment into the treatment. What's your experience with, let's start off with a truly premenopausal woman, let's say 39, 40 years old, having regular normal menstrual periods, and now is faced with breast cancer that is node positive and may need to have 4 to 6 months of chemotherapy, then followed by the anti-estrogen therapy. What do you see as your role of how you can help a woman, and where would be the opportune time for you to be involved in the care of the woman? Obviously, when someone is diagnosed with cancer at the age 40, almost everyone goes, this is my priority right now. And the idea of I might be thrown into early menopause sort of takes a very back seat to the idea of we need to cure the cancer.
Right. I think that's actually true at any age the cancer is diagnosed, because again, the main concern is got to get through this, and that's the main priority. And then once they get through the initial treatment, and then they're into survivorship, and then see the effects of all that treatment, then it's like, oh, now we have to deal with this. So I think that most of the time I will see these women after they've completed their initial surgery, chemo or radiation, and now they're into, they're about a year
Maintenance.
out. Yeah. Year
either
to 2 years.
tamoxifen
Yes.
or an estradiol
Yes.
or letrozole.
Yes. That's where I tend to get involved.
So now the cancer treatment's over, they're cancer free, and they're told, and you have to be on this medicine for 10 years.
Yeah.
And maybe talk a little bit about it. I don't know if there's been studies that show this, but it sure seems like a woman who goes like from age 40 or 45 normal menstrual periods and just gets slammed into menopause, within a few weeks, as opposed to what happens in the natural world of kind of gradually easing into menopause. It seems like it's a very abrupt, and that the symptoms are more bothersome and affect the quality of life more in that artificial inducement of
they can menopause. They can be, although it can really vary across the spectrum. I mean, I have women come in that have had a hysterectomy and they've had their ovaries out, and they say, well, I didn't really have any problems, whether they had a cancer involved or not.
Gotcha. You're right. That would be the classic idea of it absolutely being thrown in.
I've had women that have come in and that really haven't had any symptoms, and all of a sudden just wham, it hits them. So I think the biggest issue with cancer survivors that have had an estrogen dependent cancer and they're not candidates to use hormone therapy is they're faced with, what do I do for my quality of life when this particular therapy is not an option for me?
Right.
And I think
so we should state
daunting.
the obvious for people who might not know what we're talking about. So if you have an estrogen receptor positive breast cancer, the idea of giving that woman estrogen to take care of the menopausal symptoms runs a high risk that you could stimulate any breast cancer cells that might still be in her body.
Right, potentially, yeah. So we typically don't use systemic estrogen therapy in breast cancer survivors.
So since for that woman where you will not use the systemic estrogen, what do you turn to? And you probably have already described those other alternatives, but maybe repeat those for us.
So then we look at the non-hormonal therapies. So the fezolinetant, the Veozah, actually has been a game changer because it's so effective at treating hot flashes, and it's so nice to have a product like that that's come out that was formulated specifically as a non-hormonal treatment for menopausal women. The biggest downfall with it is pricing, obviously, and insurance. Some insurances aren't covering it,
Okay.
so that can be a barrier.
What about side effects of the medicine?
The side effect of that medication is mainly GI, but very few women report that.
So like nausea?
Yeah, not stomach upset, nausea. That's the main one. Then there was I think one patient in the clinical studies that had some elevation of their liver enzymes. So the recommendation for women that are starting that medication is to get baseline liver enzymes and then check them monthly for the first 3 months, and then at 6 and 9 months to make sure they stay normal. And then if they're fine, you don't have to check them anymore. And then our other options are those off-label medications. So the antidepressants, the gabapentin, the oxybutynin. Those are the most effective and the most studied. There is a procedure called a stellate ganglion blockade, just kind of like getting an epidural type injection. That's shown some promise, but it's invasive and you have to do it every 3 months. So it's really not mainstream.
Gotcha. And so that's the nerves that are somehow related to the vagus nerve, or what?
I can't tell you for sure.
It's one of the nerves that helps
With
this
the temperature regulation.
vasoactive process that causes the hot flashes.
Right.
Okay.
And then clinical hypnosis has some data to support its use, but like I'm not sure where to get clinical hypnosis done. So
are there situations in which a woman with an early stage estrogen receptor breast cancer could receive estrogen? I mean, have you ever been involved with a discussion of risks and benefits, and someone's life is so miserable from their menopausal symptoms and their breast cancer such a highly favorable histology and stage that one would consider the benefits outweighing the risks in terms of using estrogen to treat menopausal symptoms in a woman who's had a prior history of breast cancer?
So yes, if we're talking about vaginal estrogen therapy, which is what we call local hormone therapy, or using the estrogen in the vagina to treat the symptoms of vaginal dryness, discomfort with intercourse, urinary symptoms like urgency, frequency, frequent urinary tract infections. We are using it in certain women, yes, in that situation. But I personally haven't put anybody on estrogen systemically that's had a history of breast cancer.
Okay.
Yeah.
There's a lot of data out there looking at the practice of medicine, especially in oncology, that would say that those of us who are taking care of patients with cancer, whether men or women, do a very poor job of talking to patients about sexual function in terms of the importance of it in their life and the way that the treatment may be affecting.
Yep.
And it's sort of this conspiracy of not wanting to talk about it. The patient thinks, well, if the doc wants to know, he'll ask. And the doc thinks, well, if the patient wants to know, he or she will ask. And so then nobody has the conversation, which is certainly takes practice and is not as comfortable as talking about, do you have a headache? Do you have nausea? Do you have any advice for how to normalize the conversation between a doctor or nurse and a patient, to normalize the conversation about asking about sexual dysfunction and how the treatment for cancer might be affecting their...
Yeah. Well, I mean, in general, when we're talking cancer, or even patients that don't have cancer, it's a difficult conversation for a lot of people to have. And the studies show that, and I'll talk about women because I treat women. So the studies show that women want their providers to ask them about their sexual functioning, and they want their providers to ask, but then providers oftentimes don't because they're not trained or they're not comfortable in discussing it. So I think until we get more people in our medical training comfortable to address sexual functioning as a important part of people's lives, an important part of the medical history and whatnot, you just need to advocate for yourself and bring it up. Because again, when we're talking about you get that cancer diagnosis, the first thing on your mind is surviving your cancer diagnosis and how is it, going to affect, if you have young children or older children, whatever, that's the main thing. But yes, it has devastating effects on sexual function at times. And that's an important part of people's relationships. And it affects not only your personal self-esteem, but your relationship with your significant other and the emotions that they go through, fear of maybe hurting their partner, can cause their own emotional distress and partners and whatnot. So the whole family dynamic can change when that intimate relationship has been affected.
And especially in the situation of survivorship care, and in this context, I'm talking about patients that are cancer-free, as far as we know, that can change with one scan, but where you're no longer focusing on the cancer treatment and you're really focusing on issues related to quality of life and talking about having conversations about sexual function. It seems to me like a totally appropriate time to really routinely, customarily, with every patient, male or female, to bring the topic up.
Yes.
Obviously, we don't force patients to talk about something they don't want to, but the more that we normalize it and make it available. What are the resources that are available? And obviously, you are a wonderful resource for our women who I'm seeing in survivorship clinic, and we talk about sexual function. And often the conversation is easy to get into because we're sort of going through the manifestations of menopausal symptoms that you're experiencing. And so at that point, it's easy to just include sexual function. But as you said, it's often an issue not just with the patient, but their partner as well. Maybe talk a little bit about what goes into an evaluation about sexual function in a woman, and at what point do you, as a gynecologist who specializes in it, bring the partner in? And let's assume, for the sake of this discussion, it's a male partner and a female patient.
So typically I'll see patients, they'll come in with symptoms, which may be vaginal dryness, painful intercourse, decreased sexual desire. Maybe they're having frequent urination or urinary tract infections, or they're just in for their general routine care. And so we have that conversation as we go through their exam. So some women bring their partners with them. Some women don't. It's really kind of a comfort level on that particular patient. And I don't necessarily have the partner come in unless they want it. But as far as resources, so for both people, the Menopause Society's website is an excellent resource for women with and without cancer and menopausal symptoms and sexual function. And that's at menopause.org. Another excellent resource is a website called prosayla.com, prosayla.com. And that's a website that was developed by an organization called the International Society for the Study of Women's Sexual Health, or ISSWSH, ISSWSH. There's a lot of words there. But that's an excellent resource for women's sexual functioning, health in general. And so both of those websites.
Where does that word prosayla come from?
I'm not sure.
Okay.
So
it's not a
no.
A medication.
No.
Prosayla.com.
Yeah, I don't know where they came up with the terminology for it, but it's an excellent resource. And those are articles that are written by providers, and they come from all areas. So OB-GYN, internal medicine, physical therapists, behavioral specialists, sexual counselors, on articles written around women's health and sexual functioning. So excellent sources of information at those two websites. And then the American Cancer Society has a pretty nice
Mhm.
patient site too, as well, for information.
So, and we've talked a lot about breast cancer. I would say another really significant set of cancers that result in sexual dysfunction are pelvic cancers, whether gynecologic or anal, rectal,
Mhm.
where women would get chemotherapy and radiation that includes the pelvis,
Right.
including the vagina and the vulva, and all sorts of radiation side effects in terms of tissue elasticity and fibrosis, etc.
Yeah.
So we sometimes bring into the picture pelvic floor therapists. Those are
Mhm.
physical therapists that have special training in pelvic issues. What is the status in Des Moines, Iowa, for individuals that are sex therapists or sexual counselors, or what's the preferred term, and does that exist in Des Moines, Iowa?
Yes, there are. I believe there's not a lot.
Mhm.
There's two, and I believe at least one of them belongs to the American Society for Sexual Counseling and Therapy. And so what they are is they are trained therapists, and they have additional training in sexual function. So if you go to a trained sexual therapist, a lot of people think, "Oh my goodness, I'm going to go and have sex in front of somebody," and it's not that at all.
Uh-huh.
So
When you said they're trained as therapists, you're talking mental health
yes,
therapists, not physical
mental
therapists.
health. So this is mental health
Right.
therapists
Uh-huh.
for sexual mental health therapy, which I advise a lot of people to do that, because especially for people that are having libido or desire issues, because that particular behavior, for lack of a better term, is what we call a biopsychosocial model of behavior. So we have biology components to that. So that's physical and mental health and well-being, or medications that you may be on that may affect your desire. Like some of the antidepressants can cause some sexual dysfunction. If you're dealing with pain from chemotherapy, radiation, whatever, whether it's involving your genitalia or other areas of your body, because if you're in chronic pain, that can limit your ability to want to engage in intimacy or sexual activity. And then we look at the psychosocial component, which is all the stresses within and outside a relationship. So counseling with a sexual therapist is very helpful for a lot of couples, women, individuals, men, to get to the root cause of some of those issues. So 2/3 of the sexual responses here, and the other third is physical. So certified sexual therapists are trained to be mental health counselors and therapists that have additional training in sexual function. And so if you go to visit one of those people, they don't tell you how to physically have sex, and you certainly don't do that in their office. They may give you different assignments to do at home in the privacy of your own home, to bring more focus back into sensations and things like that. And then they also get oftentimes to the root causes of underlying issues that may be affecting that desire, which are basically relationship issues in some way, shape, or form. Then we also have physical therapists that specialize in pelvic floor physical therapy, and we have quite a few in the Des Moines area, and they do a wonderful job. And so what they do is they help you isolate those muscles in your core and your pelvic floor to help strengthen those muscles, which can help with if you're experiencing urinary symptoms, if you're experiencing pain with sexual activity, or like for exams or whatnot. Working with the muscles in the pelvic floor, very helpful for those types of issues.
So when we think of radiation fibrosis, this is stiffening of the soft tissues. It can be QT scan, the fat just beneath the skin, the muscles, the tendons. There are proven evidence-based methods of loosening that up. So if we're talking about the neck for somebody who had head and neck radiation, or the chest wall for somebody who had breast, I mean, we've got physical therapists, massage therapists, doctors of osteopathic medicine doing OMM that work on that. Does that same sort of manual therapy work in the pelvis?
Yes.
And so a pelvic floor physical therapist would actually do that sort of massage that could help improve elasticity or...
Yes. So they are trained to do both internal exams or therapy and external, but that's always dependent on the patient's preference. So if a patient isn't comfortable with that, they don't necessarily have to do that, and they can still gain benefit from going to the pelvic floor physical therapist. And oftentimes it's the pelvic floor physical therapist that, if we're talking about using dilator therapy, if there's been stenosis or a narrowing of the vaginal canal, that's a very helpful and effective therapy to kind of help with that aspect. And they do.
And the pelvic floor physical therapist would be a good person to help them with sort of hands-on training of the proper methods to use.
Yeah, they don't just hand them to you
instead
and say,
of just,
here you go.
Well, that's kind of what happens in the world of radiation therapy. Is you're handed a dilator. And so in the world of male sexual function, you know, I don't send those patients to you. I send them to a urologist, because there are not only medications, but there are surgical procedures that are done to enhance erections. Are there any surgical procedures that are done on women to enhance sexual function? And I'm talking primarily in the context of dysfunction related to cancer treatment.
Right. Not really.
Okay.
I mean, if a woman has a lot of pain in the vestibule, which is the part of the vagina at the top, is between the clitoris and the urethra, whether they've had cancer or not. And now if they've had radiation therapy, they probably wouldn't have any kind of surgery there because healing's poor. But for someone that hasn't had radiation therapy, that's having a lot of vestibular pain, if some of the topical medications and other therapies aren't working, sometimes they'll take that particular area and excise it. There's also, people may have heard of a Mona Lisa laser therapy. That's a therapy that has been promoted to relieve pain in the vagina due to atrophy, and is a potential for non-hormonal therapy in cancer survivors that can't use estrogen. But the studies are still not robust on that as a therapy to treat pain. So it's not being used a lot. It's not recommended at this point.
Okay. Yeah. Well, this has been very helpful. We've got about 10 minutes for questions and answers. So let's turn it over. We've got a live studio audience. We also have individuals that are watching us live streaming. If you're watching us live streaming, please put your questions in the comments section, and we will bring those to Dr. Karen Kemp-Glock's attention. We'll start with our live studio audience.
Does men have menopause? Do they go through menopause?
Is there menopause? Is that a real thing?
I probably am not the person to answer that question. There's quite a few men that are on testosterone therapy for decreased levels, but it's really outside of my wheelhouse.
Yeah.
So,
I would say I don't know. I would suspect when you look at just testosterone levels and what is listed as normal levels, the normal levels that they'll tell you is normal does decline as men get older. But it's also very true that men can still and do father children at advanced age and can get erections and ejaculations and still have sperm that are working. So there's no doubt, just from life experiences, that men have a longer period of fertility than women do.
Yes, exactly. So from the perspective of reproduction and fertility, yes, men, we know, father babies into their 80s sometimes. Yeah.
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 So was in a conversation with a urologist, and apparently they're seeing more sexual dysfunction in younger men attributed to too much availability of pornography, and that that's somehow
Well,
changing expectations in real life.
maybe. Well, male sexual dysfunction also has a psychosocial component to it. It's not just a physical inability to have or maintain an erection. So there's, for both females and males, there is certainly a component that's in the psychosocial realm. So I could see where that maybe could be
Plays
an
into
issue.
it.
Interesting.
George.
Yeah, question regarding men. How much of the distress with women in menopause is because the male partner is not engaged, is not interested, doesn't seem to understand, doesn't have the knowledge base that they should have? And I'm kind of flashing back to my earlier days when I was first married. Lamaze classes. You were expected to go, and there was pressure. You're going to go, and most guys did. And I think it did some good, but would something like that work with menopause, or something like that already being done?
I don't know. I think that what drives a lot of women is they feel like they're going crazy. I mean, I hear that day in and day out. I feel like I'm going crazy. I don't feel myself. Some of them come in because there's discord in the marriage, because there's snappy and grumpy, and their spouses and their children don't understand what's going on. So yes, education would be helpful. And then the other component to it is when we get into some more of the libido issues and the decline in desire, and that creates friction in the relationship. And oftentimes that will bring women in because their husbands are thinking there's something wrong with them, and it's a relationship issue, or the sexual dysfunction with pain. But yeah, I don't think there's really much in the way. We're just now educating women on menopause, so I don't know that we have really delved into educating their partners. Although I have some women that come in that say their husbands are very engaged and they're looking at the same websites, and sometimes they're pushing them to come in to talk about it. So as it's becoming more common in society and is kind of at the head of our news front right now, I think you're seeing a little more engagement from some people.
Yes, Kevin.
Yes, the pandemic gave medical researchers all over the world big opportunities to study different populations. And I read the other day, they were looking at prepubescent girls that are in social isolation, in various stages of social isolation. But are you aware of any studies where we're looking at older women, how the various COVID strategies might have changed onset of menopause?
I don't think there's anything that showed it changed the onset of menopause, but definitely social isolation for older women and older men. We do see an increase in like dementia. I mean, that's one of the, because when they're socially isolated and they're not engaged and they're not stimulating their brain, their loneliness, we see a definite decline in cognitive ability. But menopause per se, I can't speak to that.
So stress. All the data looking at stress. So there's a factor of stress in onset of menopause.
I don't know that stress in and of itself would cause someone to necessarily go into menopause, but we definitely can see disruption in the menstrual cycle with stress. But when that stress is relieved, they'll usually resume menstrual cycles. Now, if someone's under a constant state of stress, that may perhaps push them into menopause earlier. But in general, I don't think that's really been studied. At least I can't speak to it.
Yeah, the whole measuring of stress and how to determine its relationship. But I totally agree with you. It's stress falls as a risk factor for all sorts of things, including cancer and heart disease and dementia. And I think we don't know exactly what we call the pathophysiology, how that manifests itself but we do believe that chronic stress contributes to chronic diseases. And one of the theories, when you look around at social determinants of health, and you can determine someone's life expectancy and their health based on the zip code they live in. And there's this concept that those that are socioeconomically on the lower rungs live their life under chronic stress. I mean, day to day, you have food? Are you going to be able to pay the rent? Are you going to get the kids to school? Is the car going to break down? That there's so much chronic stress in individuals that are on the lower rung socioeconomically, that is part of what contributes to the fact that those individuals also have a higher rate of all of the chronic diseases. One more question.
Should a woman rely just on her OBGYN for her menopausal issues?
No, that's a good question. All primary care physicians, her internist, her family doctor should be versed in menopause, and her specialists too, because so when I go to my menopause meeting and they ask who's from what specialty here, there's a lot of primary care, internists, urologists are becoming more attuned to it, OBGYNs, because, you know, we've kind of been the forefront of women's health. But a lot of these women, they go to their internist or they go to their primary care, and if they're not comfortable discussing these issues, then they sort of get out in this never land, or they get unheard. Plus, it's not just, I mean, there's cardiac function, there's lung function, there's everything else. So it's a whole, it involves all the systems.
Yeah.
So
in a perfect world, a really good internal medicine doctor should want to be involved in all of that aspect.
Yeah.
But you're right, in the world of sexual, I mean, you can bring in endocrinology and other subspecialties of internal medicine, but I suspect that most women and men would think, okay, female sexual function, this is the gynecologist I need to go to, and I won't say anything to my primary care doctor.
Yeah.
Well, this has been great.
Yeah.
Thank you for being our guest
Thank you for
tonight.
having me.
If you know someone that would benefit by watching this program, it will be available on demand beginning tomorrow at the Above and Beyond Cancer YouTube channel and the Mercy Cancer Center website. Thanks for joining us this evening. I hope you'll join us again next week. Thanks, everyone.